We have about 5 minutes for discussion. I just want to remind the audience, if you want to submit questions, type in Methodist, and then from there you can submit your questions. The first question we have is, do you think there's a need for distal perfusion for femoral cannulations? I'll defer to Dr. Skipper, who is our cannulation expert.
I think we're all pretty expert at cannulation. I think most of the time that's not the case. I think there are some exceptions with regard to distal perfusion. As Dr. Nguyen alluded to, sometimes vessels are extremely small, and in younger patients, they're often very vasoreactive. So if you have a situation where you think you're going to have a prolonged pump run, and you have a small vessel, so you're going to have very little flow around your cannula, you might want to consider it. Or you could use the methodology that Dr. Nguyen suggested, where you use smaller cannulas in each groin. I also think in that situation, if you're thinking about distal perfusion, you should probably think about putting your venous cannula in the other leg. You certainly wouldn't want to impair arterial inflow and venous outflow if your vein's small. But I think it's a very rare situation.
I have a question for the panelists. So after Dr. Reardon's presentation this morning, obviously TAVR's here to stay. What do you think the role is for minimally invasive approach in this exploding era of TAVR? Are we going to be doing any more surgical valves? In the ACC 2019, we all suspect the low-risk trial is going to reveal probably non-inferiority and perhaps some benefit. So what that means is a lot of these low-risk patients are probably end up getting TAVRs as well. So what's the role of SAVR and potentially the minimally invasive approach in this era of TAVR?
So if I can answer first, I don't know if it's working. It's working, yes. Surely it is a role. It should be a role. There is an increasing interest in TAVI, no doubt, no matter. There is a real minimal invasive solution, no cardiopulmonary bypass, no anesthesia, only sedation. But we have seen this morning, there is still an open question about durability. Personally, I feel there is a question related to the real bicuspid valve, which are not so few patients. So all the younger population is still a surgical population who has bicuspid disease. And in any case, low risk for me, it's undoubtedly a good indication for surgery, because even if durability is a question that will be solved in future, I think there is another aspect, which is the cost. So costs are much less with surgical AVR. And I do not know how countries like in Europe, we have many that can afford all this, even extension of indication in more than 90 years old patient, in which we probably prolong only the life expectancy of 6 months. So we have to keep surgery as a good, honest, long-term solution. And done with a minimal invasive is surely something that give us better outcomes in terms of clinical short term, but even in long term.
Okay. I'm glad the questions are coming in from the audience. We'll try to tackle some of them, although our time is limited with a couple more minutes left. So what's advice to have to start a minimally invasive valve program, knowing that adverse outcomes can definitely impact referral patterns and obviously patient outcomes? What maybe one or two advice from the panelists in creating a mixed program to make sure that it's successful? Dr. Skipper.
I think you have to set yourself up for success, and you need to really handpick your first cases and ensure that they do very well. I think if you bite off more than you can chew, you'll end up behind the 8 ball. And so I would just say be very selective and cautious. If your outcomes start off really good, then the referrals will follow.
Dr. Glauber.
Also, I'm sorry. I was going to say, also don't start off in a vacuum. There's, this cardiac surgery world is a small world. We all love to help each other. There's a lot of collegiality, and going off and visiting Tom or one of these guys, visiting someone who does these cases all the time is a good start. Once you've picked your team, you have everyone ready. I think there's a lot of opportunity to be mentored by people who do minimally invasive surgery every day. And that's, when I finished residency, right before I finished residency, I went and visited Larry Cohn one day and watched him do a mini sternotomy AVR and went back and started doing them. And that's, it really helps to learn from the experienced people. And a lot of times there are a lot of ways you can reach out to people who do them every day.
I think you have two options. One is, or you buy and enroll an expert surgeon who is doing minimal invasive. You pay him, and he comes in your centers and he teach, and he starts the program. The other one is with your effort and with your forces, you start the program, selecting patient with a proctor, with a traveling surgeon who is going and looking so as to catch from many different surgeons different tips and tricks. But we know as to grow slowly, consciously, that we don't need to put too many different learning curves together at the same time. So,
I think in the interest of time, I'm sorry, we have to move on. I would like to thank the faculty and every speaker from this morning very much for their contribution. It was very exciting to hear all these talks. Obviously, a lot of stimulating talks, and I think there's going to be plenty of opportunity this afternoon in the lab to ask your questions directly with faculty as they demonstrate their techniques.